Good evening to everyone and welcome to today's wonderful evening with Dr. Murli Bharadwaj. Preparation to the NEETPG is the preparation to 820 topics. So we start with general medicine. In that we finished the first topic yesterday, but I will update that video. So we are still at the second topic and you will get the note shortly. Now, the second most high-yield topic is electrolyte disorders. Every entrance you go, one question will come quickly. At least first part you get the Xerox. Yeah. So, sodium disorders. Have you heard of SIADH? In a person in whom there is no edema, who is not dehydrated, who is euvolemic. Whenever you find hyponatremia, you need to think of SIADH. So, whenever we are dehydrated, obviously our osmolarity will increase, and that stimulates the pituitary to produce the ADH. When do you call inappropriate? Whenever you are not dehydrated, you are not edematous, though you are euvolemic, if the pituitary is producing the ADH, then it is called inappropriate ADH secretion. So that is the reason a euvolemic hyponatremia with a normal BP, you need to consider SIADH. When will hyponatremia lead to symptoms? Normally 135 to 145 is the sodium levels. But it is less than 125, then the patient become altered sensorium. In some people in acute state, even 130 to 130 also will lead to hyponatremia. Next, how will you correct hyponatremia? You need to give sodium supplementation in the form of normal saline. And you should never increase the serum concentration more than 0.5 millimoles per hour. Otherwise, what is the complication that will occur? Central pontine myelinolysis is the complication. Similarly, diabetic patients in whom the hyperglycemia is there. Can you please check, is the voice loud and clear? Anu? Is the voice loud and clear? Yeah. Is the video fine? Well positioned? Okay. Dilutional hyponatremia. For every rise of the serum glucose by 10 milligram per deciliter, there is an effect on the sodium levels. Similarly, there is an entity called cerebral salt wasting. It is also called CSW. In this, there is, along with the salt, the person loses water. That's the reason he is hypovolemic. And for cerebral salt wasting, which is a differential diagnosis to SIADH, we treat with fludrocortisone. What is the specialty of fludrocortisone? It is a steroid with salt retaining property is what we need to remember. Then always know, edema is synonymous with hyponatremia, whereas dehydration is synonymous with hypernatremia. Hypernatremia lead to convulsions, increased intracranial pressure is what we need to remember. So whenever there is a congestive heart failure with an edema, all the fluid inside the plasma leaves the plasma. Effectively, intravascular plasma volume become diminished. And that diminished intravascular volume will lead to the development of hyponatremia is what you need to remember. Hypothyroidism lead to hyponatremia. And hyponatremia typically presents with drowsiness and over a period of time, seizures if you don't treat. Now, Favorite question of the examiner. SIADH, cerebral salt wasting. How do you differentiate between the two? Typically, the volume, hypovolemia is the rule of cerebral salt wasting. Euvolemia is equivalent to SIADH is what you need to remember. So how do you manage the hyponatremia? We basically give hypertonic saline 3%. Why do we give? 1 liter of normal saline, which is 0.9% saline, typically will supplement 154 milliequivalents. Whereas 514 milliequivalents are provided by 541 milliequivalents are provided by 1 liter of hypertonic saline. That's the reason we give hypertonic saline, because you need to give very little fluid, around 300 to 400 ml of hypertonic saline in order to bring back the sodium to normal. Similarly, desmopressin, it prevents the overcorrection. Tolvaptan, what is tolvaptan? It is inappropriate ADH production, excess ADH. We use an antagonist of the ADH. That is especially used for euvolemic hyponatremia like SIADH, we use tolvaptan. Have you any time used it in internship? Tolvaptan comes like a tablet called Natrice, 15 milligrams. We give twice daily. Okay? Now, we use demiclocycline. Whenever there is any chronic SIADH, we use demiclocycline. Demiclocycline is a tetracycline. And demiclocycline will cause a receptor level resistance to the action of ADH. That is the reason when excess ADH is there, to counter the ADH action on the receptor, we give demiclocycline. And what is this entity, doctor, where the pons undergone demyelination? This part is pons. This white area is demyelination. Rapid correction of the sodium will lead to the development of the osmotic demyelination is what you need to remember. Now, what are the important things that you need to look for in SIADH? The urinary sodium become more than 40 milliequivalents typically, right? And because of the excessive antidiuretic hormone, the water cannot enter into plasma, into urine. So urine osmolarity increases. So urine osmolarity more than 100, serum osmolarity less than 275, urinary sodium more than 40 is diagnostic criteria to call that as SIADH is what you need to basically remember. Similarly, whenever SIADH is considered, you should rule out hypothyroidism. You should rule out adrenal dysfunction. You should rule out cardiac dysfunction. So only in the absence of thyroid disease, adrenal disease, cardiac disease, the presence of hyponatremia in a euvolemic individual whose urinary osmolarity is more than 100, plasma osmolarity less than 275, urine sodium more than 40 is the diagnosis of exclusion, which is called SIADH, is what you need to remember. Now, a lot of times we give TPN, total parenteral nutrition. That central line often delivers high concentration of sodium infusions that can lead to development of hypernatremia. So now, quickly, few points in electrolyte disorders. Often the examiner wants you to know the high facts on the basic innate physio. ADH is produced not in pituitary, it is only stored. It is originally produced in supraoptic and paraventricular nuclei. Pituitary only stores it. And it is the V2 receptor, which is the aquaporin 2 channel insertion in the collecting duct where the ADH will be acting. And the osmoreceptors are located in the hypothalamus, and it can sense even 1 to 2% change in the osmolarity is what you need to remember. Now, one of the closest differential diagnoses for SIADH is psychogenic polydipsia. Few psychiatric patients excessively drink water. Nowadays, a lot of YouTube interviews by a lot of quacks. You drink more water, you live 120 years. Every Satyababu, Seenubabu, everybody is today a YouTuber influencer deciding how much water we should drink. So ADH, so how do you differentiate? Thirst is preserved in psychogenic polydipsia. Thirst. Whereas that is not so in SIADH. Then psychogenic polydipsia has a hypotonic urine and low urine osmolarity. That is a common thing between both SIADH and this. Then in some patients, especially surgery patients, post-operative pain also will stimulate the ADH release. So it is not only a dehydration with the increased plasma osmolarity that stimulates, even non-osmotic ADH release can occur with post-operative pain is what you need to remember. Right? Then in all the causes of hyponatremia, okay, if you look at urinary sodium, not only plasma sodium is low, urine sodium is also low. But what is the specialty of SIADH? Plasma sodium is low, but urinary sodium is high, is what you need to remember. First of all, what happens in SIADH? Whenever SIADH is there, ADH will lead to water reabsorption. That reabsorbed water will expand the plasma volume. That will cause the stretching of atria. That release the atrial natriuretic peptide. That lead to development of the natriuresis and increase in the urinary sodium. That's the reason. Other causes of the hyponatremia, like decreased intake, there is a low urine sodium. Whereas in SIADH you have high urinary sodium, which is a differentiator, is what you need to remember. So SIADH is euvolemic with urinary sodium more than 40 is what we need to basically remember. So euvolemic hyponatremia, if it is there, euvolemic hyponatremia, which is SIADH, we give tolvaptan and all these drugs. But a hypovolemic hyponatremia, like an edematous person, dehydrated person, there you need to give fluid replenishment in the form of isotonic saline, normal saline, is what we need to remember. So, doctor, in every case of hyperglycemia, while you are interpreting sodium, be careful, because hyperglycemia lead to hyponatremia, but that automatically corrects with the correction of glucose. You don't need to give the sodium. Then cerebral salt wasting treatment of choice, fludrocortisone. So these are the 2 points you need to remember. That's all. Now you are ready. Any question that comes on sodium, you are ready. Now let us talk calcium. So totally 52 topics, from which 30 MCQs in the NEETPG will come. समझ लो 15 minutes, 15 minutes is one topic. So 1 hour, 4 topics, 52, 12 to 15 hours. General medicine, khatam. Anything you are ready to face. Okay. Now, calcium disorders. Yes, gone. Can you please check where is it? Can you please check the video fine? Can post it in WhatsApp. Yeah. Now, what is the granulomatous disorder where you find hypercalcemia? Sarcoidosis. There, the macrophages in the granuloma will produce vitamin D-like substance. That increased calcitriol will lead to hypercalcemia. That's the reason hypercalcemia is found in sarcoidosis. And always remember, a low calcium stimulates PTH, high calcium suppresses. That's the reason. What is the combination in sarcoidosis? High calcium, high calcitriol, low PTH is the combination. Whereas hyperparathyroidism, high calcium, high parathyroid. That is how you differentiate sarcoid from hyperparathyroidism. In hyperparathyroidism, this kind of subperiosteal resorption is classical feature. A lot of times they say image-based MCQ in the exam. There is development of the brown tumors in hyperparathyroidism. Hypocalcemia lead to tetany. Hypoparathyroidism, there is a hypocalcemia. Hyperparathyroidism, generally there is hypercalcemia. Rule. Hypercalcemia is synonymous with hyperparathyroidism. Hypocalcemia is the rule in hypoparathyroidism. So what malignancies can lead to hypercalcemia? Breast cancer, non-small cell lung cancer, prostate cancer because it leads to osteoblastic metastasis, and myeloma, multiple myeloma. All of these can cause. Thiazide diuretics lead to hypercalcemia. So don't forget favorite MCQ. Loop diuretics lose calcium, thiazide diuretics increase calcium. This is a very important rule that you need to remember. Loop diuretics like furosemide, torsemide, ditar, they all will lose calcium. So whenever somebody is having hypercalcemia acutely, how do you treat? By giving loop diuretics at the same time, IV saline. Otherwise, he becomes dehydrated. Whenever vitamin D is excessively taken, intoxication is there. There is a low bone turnover, and that can lead to hypercalcemia, vitamin D intoxication. So whenever hyperparathyroidism is there, how do you treat that hypercalcemia? We give biphosphonates, calcitonin, plicamycin. So don't get confused between calcitonin and calcitriol. Triol is vitamin D. Calcitonin is opposite. It leads to lowering of the calcium. So biphosphonates, calcitonin, plicamycin, treatment of hyperparathyroidism. And whenever there is a hypercalcemia with a low PTH, what are the two reasons? Vitamin D intoxication, even malignancy also, PTH is low. Sarcoidosis also, PTH is low. Hyperparathyroidism, PTH is high with hypercalcemia is what you need to remember. So what is this, doctor? This is malignancy, vitamin D excess leading to hypercalcemia and low PTH. Now always, calcium is bound to the albumin. Calcium is positively charged, and there are anionic charges on the albumin. So whenever you are interpreting the serum calcium levels, compare with albumin. Albumin levels. Suppose somebody is having nephrotic syndrome. His albumin is low. That will affect your ionized calcium level estimation. Somebody has multiple myeloma, hyperproteinemias, Waldenstrom's macroglobulinemia. In all these entities, typically calcium levels get altered. So that is the reason, don't depend on the total calcium, but rather on the ionized calcium to decide the calcium ion disorders. is the rule. Then there is one entity called hypercalcemia due to hypocalciuria. What is that called? Familial hypocalciuric hypercalcemia. What is that called? Familial hypocalciuric hypercalcemia. This is the only entity that differentiates, that is different from other causes of hypercalcemia. Why? In all other causes of hypercalcemia, there is high calcium with high serum calcium and high urine calcium. But what is the only entity where there is a hypercalcemia with a low urinary calcium? Familial hypocalciuric hypercalcemia. Basically, there is a problem in the channel in the kidney. It stops losing calcium into urine, and it leads to more calcium retention into plasma, leading to the hypocalciuric hypercalcemia, is what we need to remember. So that is all the story you need to know, doctor. Now, few more things in electrolyte disorders and at physio. There are 4 glands posterior to the thyroid lobes. Embryologically, superior parathyroid glands arise from 4th pharyngeal pouch, reverse. Inferior from 3rd pouch. 3rd ऊपर रहता, 4th नीचे रहता, मगर superior नीचे से, inferior ऊपर से. What is the action of PTH? It resorbs the bone and it will affect the renal calcium reabsorption. It will increase PTH. Always remember, PTH in the proximal canal tubule increases reabsorption of calcium, but increases the excretion of phosphate. It leads to phosphaturia. That's the reason what will happen in hyperparathyroidism. More calcium is reabsorbed and leading to hypercalcemia, but more phosphate is lost into urine, leading to hypophosphatemia, is what you need to remember. Right? Now, if you look, the 4 parathyroid glands, superior, inferior, its embryology, you should not forget. Now, one of the favorite question, how do you differentiate the different types of hyperparathyroidism? Primary hyperparathyroidism. What is it because of? Parathyroid adenoma. Okay. Whereas, what is secondary hyperparathyroidism? Whenever you have renal failure, you are not producing vitamin D, that decreases the calcium level, and that low calcium stimulates the parathyroid to be produced more, and that increased parathormone will go to the bones. It will reabsorb the calcium from the bone. That's how the calcium level, which is initially low, will become normal. So, secondary hyperparathyroidism is a feature of renal failure. So, it starts with low calcium and become normal calcium, whereas primary hyperparathyroidism is a parathyroid adenoma, and typically it leads to hypercalcemia, is what we need to remember. Manu, is it loud and clear? Can you please? Now, whenever bone metastasis is there, that lead to osteolytic lesions, that lead to hypercalcemia. Thiazides retain calcium, loop diuretics lose calcium, is what we need to remember. Right, doctor? So, you need to remember, whenever primary hyperparathyroidism is there, you want to detect the parathyroid adenoma, the best imaging modality will be doing a sesame scan, is what we need to remember. Right? Now, biphosphonates, typically zoledronic acid, alendronate, all these are used to treat the hypercalcemia. I mean, the bone resorption, osteoporosis, and they won't have immediate effect. They take 48 to 72 hours. Right? Now, acute severe hypercalcemia. How do you treat? We give IV saline hydration first. Then we give biphosphonate to inhibit the osteoclast, but they have a delayed effect. And then we give calcitonin. There is something called salmon calcitonin. Have you seen that anytime? It's available as a nasal spray. Calci spray is the brand. So inhalation of that will provide a temporary, rapid calcium lowering effect. And definitive treatment of the adenoma is parathyroidectomy is what we need to remember. Sometimes patients can have ectopic parathyroids, especially in the mediastinum and in the capsule of the thyroid. 3 to 5 glands are possible, right? So when examiner asks how many parathyroid glands, generally 4 is the answer. Now, if you look at the thiazides, ACE inhibitors, etc., thiazides impair the dilution and they cause hyponatremia. Then ACE inhibitors, what is the normal function of aldosterone? Retain sodium, lose potassium. So if you give an ACE inhibitor, you are inhibiting angiotensin 1 production and aldosterone production decrease, and that will lead to losing sodium and retaining potassium. That's the reason all ACE inhibitors, ARBs, you need to be watchful on hyperkalemia and hyponatremia. That's what we need to remember, right? Now, a lot of questions come, typically electrolyte disorders, freshwater drowning. What do you get? Hyperkalemia. Heat cramps is due to salt depletion. Then brain injury leading to altered sensorium is a feature of hyponatremia, right? A lot of times question is asked on the drowning type. Freshwater drowning, hyperkalemia. Seawater drowning, hypo, right? That is a fundamental difference. Then free water deficit is a favorite question of the examiner. Percentage of the body water into mass into current sodium minus ideal sodium by ideal sodium will give you the water deficit. What is water deficit? Percentage body water. Normally, it is 50%. Right? Into mass, let us say 70 kgs. Let us say the person is having hypernatremia, 167. Normal value is 145, upper limit, divided by 145. That gives a water deficit of 5.3 liters. As I rightly told you, in the topics, entire medicine, very good. Any page lo vachindamma? Entire medicine. Huh? Cool, eh? So Suresh, you are a hero, Suresh. Because entire medicine you have cramped into 102 pages means NEETPG students will give you a garland. If you master this 102, out of this 1 or 2 pages, all 30 questions will come. But it is thickly dense. You need to have that logic in mind, like our physics problems in intermediate. All right. You are able to identify where you are? Yeah. Pakkane, what you do is you write some logical points that we discuss. Now, that is the story, doctor. Now, ringer lactate, How much sodium will be there? 130 milliequivalents per liter. Normal saline, 0.9%, 154 milliequivalents per liter. Right? So dextrose 5%, initially it is isotonic, then it becomes free water. Because dextrose is metabolized, no? Then whenever there is a metabolic acidosis, do you prefer ringer lactate or normal saline is a favorite question. Ringer lactate is the fluid of choice. So how much sodium is there in ringer lactate? 130 milliequivalents per liter. Sodium in normal saline, 154 milliequivalents per liter. Freshwater drowning is hyperkalemia. So these are the fundamentals. Then another favorite question of the examiner, doctor, what are the ECG changes? Prolongation of the QT interval. This is the ECG you should remember. Prolongation of QT interval. That means from the start of the QRS complex to the end of the T wave, QT interval. Prolongation of the QT interval is the feature of three things: hypokalemia, hypercalcemia, macrolides. Similarly, peaked T wave, peaked T wave is the feature of hyperkalemia. Right? Then presence of U wave. What is U wave? After T wave, any wave is called U wave. It can be negative, it can be positive. Is a feature of hypokalemia. Prolongation of the QT interval is a feature of prolongation of the QT interval. We said hypokalemia, hypocalcemia, right? Hypomagnesemia and using macrolides. Any of them can cause prolonged QT interval is what we need to remember. So whenever somebody is having hypokalemia, normal potassium is how much? 3.5 to 5. If it is around 2.52, you need to replace it. So through the peripheral venous line, the maximum limit is less than 10. Whereas through central line, you can be able to give up to 40 millimoles per hour under monitoring is what we need to remember. Okay. Now, in acute hyperkalemia, where do you come across acute hyperkalemia, doctor? In chronic renal failure, very commonly we find hyperkalemia. You need to give IV calcium gluconate immediately. Why do you want to give calcium gluconate? It will prevent the heart from going into VTVF to avoid cardiac arrest, not to lower the potassium levels. That's a very important point. And what is meant by Torsades depointus? It is called polymorphic ventricular tachycardia. You know VT, ventricular tachycardia? It's a broad QRS complex tachycardia. So whenever there is a long QT interval, you will get polymorphic VT. When do you call long QT and interval? Normal QT is how much? Corrected QT interval is 420 milliseconds. More than 600 milliseconds lead to ventricular polymorphic VT. So there the treatment is IV bolus of magnesium is what we need to basically remember. Once more, peak T waves is a feature of hyperkalemia, U waves in hypokalemia, prolonged QT, Torsades depointus. These are the points you should not forget. So can you see in this ECG, doctor, classically you are able to see T waves. After QRS, the T waves are peaked. Where else you get a peaked T wave? Even in acute myocardial infarction, you get hyperpolarized T waves. But how do you differentiate? Symmetrical peaking is the feature of hyperkalemia, whereas asymmetrical peaking is the feature of the T wave is the feature of MI, is what we need to remember. Now, doctor, what's the count? Manu? Count. Okay. Just inform them too. Hyperkalemia, we get peak T waves. Hypokalemia, we get the U waves. Another important rule. Acidosis, which dyslipidemia you get, doctor? Acidosis, you get hyperkalemia. Metabolic alkalosis, you get hypokalemia. Easy to remember. Itla gurtupeట్టుకోండి. There's a competition between two sisters to marry the same boy. Who are they? Potassium H+. Both want to go inside. So one of the sister will do sacrifice. Right? Who is that sister who does sacrifice? K+. So instead of going into the cell, whenever acidosis is there, it lets H+ to go inside. Understand? That will increase the potassium levels in plasma and that lead to hyperkalemia. Wouldn't it? Hyperkalemia is a feature of acidosis. Hypokalemia is a feature of metabolic alkalosis. Whenever you give a loop diuretic like furosemide, typically it leads to hypokalemia. Good. Is it fine or we will remove that central? It's better you remove that center. That's fine. So good, doctor. Now, furosemide, loop diuretic lead to hypokalemia. Among the HIV drugs, favorite question of the examiner, raltegravir leads to hyperkalemia is what you need to remember. And another thing about ECG is, in spite of hyperkalemia, ECG can still remain normal is what we have to remember. Okay, so what are the long-term therapy of hyperkalemia? We give diuretics like the loop diuretics, dialysis, and we use the potassium binding resins also we give in order to treat the hyperkalemia. Now, what is the relation between insulin and potassium? Insulin moves not only glucose into the cell, but also potassium into the cell. That's the reason we administer insulin. At the same time, we will give glucose, right? IV glucose also, in order to treat the hyperkalemia is what we have to remember. That's the reason we give 50% dextrose along with insulin, diuretics, dialysis, and potassium binding resins is the part of the management of hyperkalemia. And what is the effect of beta-2 agonistic drugs on potassium? Commonly used beta-2 agonists like salbutamol, nebulization cannot push the potassium into the cell. That's the reason we use nebulized salbutamol to treat the hyperkalemia is what we need to remember. So immediately give IV calcium gluconate, give insulin plus 50% dextrose is considered to be the treatment of choice. Then whenever you are using a hemolyzed sample, the nurse has drawn the blood. By the time the blood sample is being sent to laboratory, if there is a hemolysis, that can lead to pseudo-hyperkalemia is a favorite question of the examiner. So insulin beta-2 agonists, they cause transcellular shift. Renal failure lead to hyperkalemia. Hemolyzed sample lead to pseudo-hyperkalemia. So these are the points frequently tested. Right, doctor? And another important point. What is the most common cause of hypokalemia in our intensive care unit, doctor? Lot of times. When you walk into ICU, everybody will be nebulized. The prolonged nebulization will lead to hypocalcemia, hypokalemia. Second thing, somebody who is there, whose hypokalemia is not responding to the potassium supplementation, replenishment, what you should suspect? Magnesium deficiency. So magnesium deficiency, unless corrected, will lead to refractory hypokalemia is what we need to remember. Okay. Now, whenever you are giving total parenteral nutrition, right, you need to closely monitor for hypomagnesemia and electrolyte disturbances. Similarly, there is an entity called refeeding syndrome. So typically, in the people who are starved for a long period of time, when you suddenly feed them, which dyselectrolytemia occur is a favorite MCQ. It is the hypophosphatemia is a very important risk. Electrolyte disturbance in refeeding syndrome is what we need to remember. Then in massive transfusion, favorite question of the examiner, what are the electrolyte disturbances? There is hyperkalemia, hypocalcemia, hypomagnesemia. Why? Transfused blood contains citrate. Citrate chelates calcium that lead to hypocalcemia. Why hyperkalemia? Transfused blood contain the RBCs. RBCs will break down and they release the potassium that lead to the development of hyperkalemia. Right? Then these are the 2 points which are the favorite questions of the examiner. Now, doctor, there is an entity called tumor lysis syndrome that you need to know. What happens in tumor lysis syndrome? Once you give, especially in tumors like acute promyelocytic leukemia, in them when you give all trans retinoic acid treatment that lead to the breakdown of the cells, potassium is intracellular ion that lead to hyperkalemia, hyperphosphatemia, because normally potassium and phosphate are intracellular. So they both get released. Phosphate sequesters calcium and that lead to hypocalcemia. So hypocalcemia, hyperkalemia, hyperphosphatemia, the combination is called tumor lysis syndrome. A lot of time examiner will try to confuse you. He will say there are bone mets. But bone mets versus tumor lysis, what is the difference? In bone mets, there is osteolytic lesion releasing the calcium leading to hypercalcemia is the feature of bone mets. But low calcium is the nature of tumor lysis, the differentiator which you need to basically remember. Right, doctor? Now, which type of tumors tumor lysis syndrome is seen? Acute myeloid leukemia, high-grade lymphoma in this. Similarly, any high LDH values in a patient who has malignancy, lymphoma or AML, you should think of the risk for tumor lysis syndrome, right? And any tumor whose LDH levels are high and it is a very chemosensitive tumor like acute promyelocytic leukemia, the risk of developing tumor lysis syndrome, the probability will be very high, is what you need to remember. So, as a prophylaxis to tumor lysis syndrome, what are the features in tumor lysis syndrome? Hyperkalemia, hyperphosphatemia, hypocalcemia, hyperuricemia. Why hyperuricemia? Because the nucleic acids are released from the cell, they get metabolized and form the uric acid, right? So that's what we need to remember. That's the reason we need to give allopurinol, rasburicase to avoid hyperuricemia. And we need to give hydration, which is very critical to prevent the development of the acute kidney injury is what we need to remember. Right, doctor? So now, one of the favorite questions of the examiner. So we finished what? In electrolyte disorders, sodium, calcium, potassium. Now let us talk magnesium. There are two entities you should remember, doctor. Bartter syndrome, Gitelman syndrome. They are the two important things you need to remember. Bartter syndrome, what is very important to know? It is like taking loop diuretics. What is a loop diuretics mechanism of action? It will go to the ascending limb of loop of Henle, you can see. Sodium potassium 2 chloride channel, it inhibits. Whereas thiazide diuretic, it will go to distal convoluted tubule and their sodium hydrogen channel it will affect. Bartter behaves like loop diuretics. Gitelman behaves like thiazide diuretic is what we need to remember. Then another important differentiator. We have hypomagnesemia in Gitelman, but not in the Bartter. That is a differentiator, right? Now, why do we need magnesium? Magnesium is a cofactor in a lot of enzymes. Magnesium prevents the arrhythmia. That's the reason in Torsades depointus, polymorphic VT with a prolonged QT, we give magnesium IV. That's what we need to basically remember, right? Then hypomagnesemia lead to refractory hypokalemia. And those who regularly take alcohol and antacid, they are the common causes of hypomagnesemia. So that is the reason whenever there is any refractory hypokalemia, treat the hypomagnesemia first. Is a very important rule. So quickly tell me 3 points frequently asked by the examiner. Bartter is a loop-like diuretic. It leads to hypercalcemia. It also leads to hypokalemia, but no hypomagnesemia. Gentlemen, hypocalciuria, hypokalemia, hypomagnesemia. So what is common between Bartter and Gitelman? Hypokalemia. So how do you treat? For Bartter, where the problem is there in ascending limb of loop of Henle, we give liberally salt, potassium, magnesium, and also we give NSAIDs, which are the inhibitors of the prostaglandins in case of Bartter, right? And always a very important rule. Hypocalciuria is the differentiator. Check the urinary calcium to know whether it is a Bartter or Gitelman. A low urinary calcium, because of the calcium retention, just like thiazide diuretics, is the feature of Gitelman. Losing calcium, like a loop diuretic, is the nature of Bartter syndrome, is what we need to remember. So Bartter is like loop diuretic and it lead to hypercalciuria. Gitelman is a thiazide diuretic with hypocalciuria. Hypomagnesemia is what we need to remember. Right, doctor? Now, that completes the chapter of electrolyte disorders. Very good. ఇప్పుడు ఎన్ని పేజీలు ఎన్నో పేజీలు ఉన్నారు కింద నెంబర్ ఇవ్వలేదు వాళ్ళు 12th page. Good. 1/10 of total medicine is over. The moment you are good in medicine, surgery, gynaps, half the game is won. Right, doctor? We'll give 2-minute break and restart. So let us continue our discussion, doctor. Arrhythmias is the next favorite topic of the examiner. So whenever there is any atrial fibrillation, if the patient is hemodynamically unstable, then what is the treatment of choice? DC cardioversion. How do you identify atrial fibrillation? Before QRS, you expect P wave. If there is no P wave, then you call it as atrial fibrillation. Whereas this kind of a sawtooth appearance, don't forget, so many times this question comes in NEETPG exam, image based. See, there are 3,000 images you should master. I'll give you those 3,000 images as a PDF. Right? Classical. All 30 questions of image based will come from that. So, atrial flutter, you find sawtooth is what we need to remember. Atrial fibrillation is also called the holiday heart syndrome. It is also called holiday heart syndrome because those who regularly consume the alcohol, they are vulnerable to develop the atrial fibrillation is what we need to remember. Now, doctor, rate versus rhythm. Whenever there is any atrial arrhythmia, the first choice is control the rate and then the rhythm. Now, what percentage of the people will develop a embolic stroke because of the atrial fibrillation? For that, we do what is called SIADH score. CHA2DS2 VAS-C is the typical score which you need to remember. If it is more than 1 in men or more than 2 in women, then anticoagulation need to be used. Mainly you need to know what C means, what H means, what is A means, etc., etc. You can just remember the acronym. So flutter waves are sawtooth, whereas atrial fibrillation is P waves, which are absent, right? Then AF is divided into paroxysmal versus persistent atrial fibrillation, right? Now, and another important thing, DC cardioversion you need to do, but you should only do if the onset of the AF is less than 48 hours. But if it is more than 48 hours, first you need to anticoagulate the patient, otherwise he will land up in stroke if you happen to do the DC cardioversion. So you can see here the left atrium developing in the 2D echo a thrombus which can undergo embolization if you don't do anticoagulation, if at all the AF is more than 48 hours in duration. So quickly, when examiner asks what are the causes of the atrial fibrillation, hypertension, coronary artery disease, heart failure, hyperthyroidism, and alcohol need to be remembered. Responsible for atrial fibrillation is what we need to remember. Now, few basics in ECG you need to know. ST segment, what is a segment and what is a wave in ECG, doctor? A segment is the isoelectric line, end of the T wave to beginning of the P wave, or end of the QRS to beginning of the T wave, or end of the P wave to the beginning of the QRS, PR segment. So ST segment, if you look electrophysiologically, it corresponds to the ventricular depolarization plateau phase. Then what is an S wave? What is a Q wave? R is a positive wave. Any wave which is negative before that is called Q. Any wave which is negative after R wave is S wave. So the lead 1 showing S wave, negative wave. Lead 3 showing Q wave, which is also negative before R wave. And T wave inverted. S1, Q3, T3. T wave inverted in lead 3. presence of a Q wave in the lead 3, presence of a S wave in lead 1. These three are indicative of pulmonary embolism is what you need to remember. But if the examiner asks a question, what is the most common ECG finding in pulmonary embolism? What is your answer? It is a sinus tachycardia. Because when there is a pulmonary embolus, who will bear the brunt? RV, right ventricle. So the right ventricle is unable to pump the blood against the severe pulmonary hypertension whenever pulmonary embolism is there. Then what will happen to the ventricle? If it can't deliver the cardiac output due to high pressure in pulmonary artery, it will go into tachycardia. Once more, you are lost somewhere. Pulmonary embolus, that will increase the pressure in pulmonary artery. And right ventricle need to pump against that high pulmonary pressure, artery pressure. So right ventricle fails. So when it fails, it can't pump output. When the output decreases, it needs to contract more often. That is the reason sinus tachycardia is the rule in case of pulmonary embolism. There is a wave called J wave, typically in the QRS complex, right? This is T wave, this is QRS. There is a small wave immediately at the end of the QRS. That small nick is called J wave, Osborn wave. Osborn wave is hallmark of hypothermia. So, if you look at the STT changes, T wave depression can occur in ischemia. T wave elevation is a feature of hallmark of MI. And electrolyte disturbances also can cause STT changes, is what we need to remember. What is the normal PR interval? So PR interval means the start of the P to the beginning of QRS, including P wave and PR segment. That is 120 to 200 milliseconds is normal. Okay, so you should know, doctor, in ECG strip, you have big box, small box, right? Each big box is how many milliseconds? 200 milliseconds divided by 5. 5 small boxes in one big box is equal to 40 milliseconds is one small box. 200 milliseconds is one big box. That's a very important thing to remember. That means PR interval should be as big as a one big box or 5 small boxes, 3 to 5 small boxes, right? Then what is the duration of QRS complex? Normally less than 100 to 120 milliseconds. Why it is important to know the QRS duration? Because whenever tachycardia is there, 140, 150 heart rate, look at the QRS. If the QRS is narrow and tachycardia is there, it is supraventricular tachycardia. If the QRS is broad and tachycardia is there, it is ventricular tachycardia. How do you decide narrow or wide? Look at the duration. The duration normally is less than 100 to 120 milliseconds is what we need to remember. Now, if you look at the QT interval, it is being normalized to the heart rate. The heart rate will decide the QT. That's the reason we correct a QT interval based on the heart rate. And what is that formula called? Besset's formula is what we need to remember. Now, we need to know that two things are the marker of MI. One is ST segment elevation, other is the hyperacute, asymmetrical hyperacute. T wave is what you need to remember. Now, coming to the normal QRS complex. Normal QRS axis is minus 30 to 110. And left axis deviation means minus 30 to This is minus 30, minus 30. This is minus 30, right? So minus 30 to minus 90. This is minus 90, left axis, right? And typically we look for the left axis deviation in which leads? Lead 1. Whenever lead 1, always left or right, lead 1, lead 2. If the lead 1 is looking up, lead 2, QRS is looking down. You remember it is left each other. If the lead 1, if it is looking down, QRS, and lead 2, if it is looking up, they are right towards each other. Easy to remember. Right axis. What is the normal axis? Lead 1, you can see here. Lead 1, it is looking up, and lead 2 also QRS is upward. If both are looking upward, Vadhu is looking upward, Varudu is also looking upward. What are they looking at? Arundhati Nakshatram. Is it normal or abnormal to marry? At least to start with, it is normal. Then in the lead 1, it is upward, but lead 2, it is downward. That is left axis. Lead 1, it is looking downward. Lead 2, it is looking upward. That is right axis. So what are the very common causes of the left axis deviation? Left bundle branch block, left ventricular hypertrophy, inferior wall MI. They all lead to the development of left axis deviation. Okay. Then a very important thing, limb lead reversal. How do you identify? See, if you look at the lead AVR, how is lead AVR obtained? By connecting your right arm with the left leg, making it one lead, and left arm and left leg, making it one lead, and looking towards the right arm. That means there is a negative. Left arm, left leg is made into one negative lead, right arm is made a positive lead, and the axis is towards from left to right, from below to above. How is our depolarization of the heart? It starts on the right side in SA node and it is going towards the left side and down. So, ये विजयवाड़ा से तेनाली जा रहे हैं और ये तेनाली से विजयवाड़ा आ रहे हैं. They both are opposite. That is the reason what will happen to in the AVR. All waves will be negatively deflected. P wave, QRS, T wave, everything. And by chance in the AVR, if all the waves are positively deflected, that means QRS, P wave, and T wave, if they are positively deflected in AVR, that is how you will identify limb lead reversal. In which lead? In AVR. Right? Now, yeah. What are the causes of the right axis deviation? So always remember, LVH, left axis deviation. RVH, right axis deviation. Then anything putting pressure on the right ventricle, like pulmonary embolism, dextrocardia, they also can lead to right axis deviation is what you need to basically remember. Right? Now you need to know a bit about the AV block. First degree block, second degree block, complete heart block. 3 types. What is the meaning of first degree block? So where is AV node located? Between atria and ventricle. So atrial depolarization is P wave, ventricular depolarization is QRS, right? So between P wave and the QRS, what is the segment you have? PR segment and PR interval. Any prolongation of the PR interval is called first degree heart block. All right, doc? First degree heart block. Generally, first degree heart block, where only PR prolongation is there, still P wave is seen, QRS is seen. There you don't need to do anything. If the patient is symptomatic, like he is getting syncopal attacks, then only pacemaker is indicated. Understand? Then the next important thing, complete heart block. Right? What is the meaning of complete heart block? P wave is there, QRS is there, AV node completely blocked P going to QRS. QRS developed its own idioventricular rhythm. So P waves are happening at their own rhythm. QRS happening its own rhythm. P, P, QRS, P, 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 QRS, 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 P. Like that if it is happening. That's called AV dissociation. Is the hallmark of complete heart block. There also you require pacemaker. Then what is Mobitz type 1 and type 2 block? There is a P wave, PR interval, QRS. P wave, slightly prolonged QRS, PR interval, then QRS. P wave, more prolonged PR interval, QRS. Then P wave, and there is no QRS. That's called Wenke-Back phenomena. Serial prolongation of the PR interval and then dropping of the QRS is called Wenke-Back phenomena. But that is predictable. What is not predictable? P wave, normal PR, QRS. P, normal, QRS. P, normal, PR, QRS. P, then suddenly it dropped. Right? What QRS dropped? What is that called? Mobitz type 2 block is what you need to remember. Between Mobitz type 1 and 2, which is more dangerous? Mobitz type 2 is unpredictable and that leads to development of a sudden cardiac collapse is what we need to basically remember. So that is the reason Mobitz type 2 block is considered to be an indication for the pacemaker is what we need to remember in exam. So what is the cause of the Mobitz type 2 block, doctor? Coronary artery disease, sarcoidosis, hypothyroidism. They're all the causes of the Mobitz type 2 block is what we need to remember. So let us summarize. First degree heart block with PR prolongation, not an indication for pacemaker. Only if it is a symptom, when it is symptomatic, it is. Second degree heart block, Mobitz type 1, not an indication, only Mobitz type 2. Complete heart block, yes, is an indication. Clear? Now, what is the hallmark? Let us go into rapid fire memory. AF hallmark, absent P wave. Right? Then normal axis, minus 30 to minus 110. Mobitz type 2 is block at the infra-His bundle. That's the reason pacemaker is needed. Right? Now, whenever there is a WPW syndrome, right? So whenever atrial fibrillation is there, what will you give, doctor? Whenever atrial fibrillation is there, what do we give? We give digoxin. Why? Because digoxin has parasympathomimetic effect. Because of that, the AV node get blocked. And that prevent the atrial fibrillation to go into the ventricle. Could you get me? Why do we use digoxin for atrial fibrillation? Atrium fibrillate aitundi. AV node conduct chase chance into the ventricle. If it conducts that atrial fibrillation into ventricle, ventricle will go into fibrillation, which is more dangerous. So you need to make AV node become refractory. For that, you need to stimulate the parasympathetic system. And digoxin has a parasympathomimetic effect. Whereas, never give whenever there is WPW syndrome, digoxin. Enduko? So, first of all, you can see, okay. Right? So what is WPW syndrome, doctor? Here you have the AV node. And there is a direct connection between atria and ventricle. So now here there is AF in this patient of WPW, let us say. If you happen to use like regular AF, if you happen to give digoxin, then you are encouraging the transmission through the re-entry pathway, and that will worsen the ventricular fibrillation. That is the reason whenever AF is there, instead of digoxin, what you need to give? You need to give a drug which preferentially will go and make this AV nodal pathway become, a re-entry pathway become refractory. That is the reason procainamide is the drug of choice to manage the AF in case of WPW syndrome, is what we need to remember. All right, doctor? Then in WPW, what is very important? The QRS complex become wide. When do you call wide QRS? If it is more than 0.12 seconds is what we need to remember. Just before we studied, no? What is the normal values? Normal QRS? 100 to 120. Anything more than 120 milliseconds is an indication of wide QRS is what we need to remember. What is Bajol-Jerisk reaction? There is a hypotension and bradycardia. Whenever the vagus is stimulated reflexly, that lead to hypotension and bradycardia. So how do you manage ventricular tachycardia? If the patient is hemodynamically stable, you'll give lidocaine and all the drugs. But if he is unstable, then you do DC shock is what we need to remember. Right? Now, let's quickly review the therapeutics and treatment. What are the favorite questions asked in exam? So you should remember this, doctor. Here you can see, this is narrow QRS complex with tachycardia. This is a supraventricular tachycardia. Whereas this is a broad complex QRS and tachycardia. Hence, this is a ventricular tachycardia. Clear? Now, whenever the patient is hemodynamically unstable with SVT, we need to give synchronized cardioversion. Is the treatment of choice. There's an entity called sinus brady, which will happen whenever inferior wall MI is there. There you need to treat with atropine is the first line of choice. Right? Then what is the indication for an automatic intracardiac defibrillator? There's an entity called Brugada's syndrome. Ventricular fibrillation. Post-MI with a low ejection fraction. They're all the indications for automatic intracardiac defibrillate. It will sense the heart rate and defibrillate. Permanent pacemaker is of two types. One is called single and other is called dual chamber. Right? And what is the entity where AV nodal blocking agents like digoxin are being contraindicated? WPW is what you need to remember. Right? Similarly, here you can see, this is the automatic defibrillator. Right? So, this is temporary pacing. Now, in the topic of arrhythmias, you need to know a bit about anatomy, etc. Right? So, where is AV node located? It is interatrial septum near tricuspid. Right? Then, where is SA node located? It is high in the right atrium near the SVC. There are the 2 points. Now, let's look into the WPW syndrome. So, you can see here, doctor, normally SA node will send to AV node, which will send to Purkinje fibers which have got the right bundle and left bundle of the Purkinje fiber is what we need to remember. Now, whenever you have a reentrant pathway, accessory pathway, then what will happen? Normal SA node will send through the AV node into the ventricle, and that lead to a QRS complex, right? And this reentrant pathway will also send a depolarization. So these two depolarizations will clash. That's the reason the QRS complex become wider. And in the initial uprise of the QRS, there is a small slurring of the QRS. So short PR interval. Normally AV node will create a delay and that is reflecting as PR. But because the accessory pathway, the PR becomes short, QRS become wide, and there is a delta wave in the initial upstroke is what we need to remember. Now, this WPW can exist on the right side and left side. Which side is more common? A right-sided accessory pathway is most common, right? Then, because of this abnormal pathway, between the atria and ventricle, there is a tachycardia which is called reentrant tachycardia. That can occur orthodromic or antidromic. Orthodromic means from atria into ventricle, or from ventricle into the atria. So, the most common type of the pathway that you see is a orthodromic AV nodal reentrant tachycardia is what we need to basically remember. Understand, doctor? 3 points about WPW. Delta wave, short PR, wide QRS. Right-sided more common. Orthodromic AVRT rather than antidromic. They are the 3 points. So how do you treat it, doctor? You will do catheter ablation of those reentrant pathways, right? Then never give digoxin or verapamil like AV node blocking agents whenever it is AF in a WPW syndrome is what you need to remember, right? Now, the next favorite aspect of the arrhythmias for the examiner is bundle branch blocks, right? Now, what is wide QRS complex? Anything more than 0.12. What is the meaning? Why QRS become wide? If the entire ventricular conduction become delayed, that lead to wide QRS. 4 most common causes of wide QRS. Number 1, hyperkalemia, wide QRS, WPW, wide QRS, VT, and bundle branch block. Any of them lead to wide QRS complex. Then, what are the 3 causes you need to remember for LBBB? Acute MI, hyperkalemia, Ashman syndrome. RBBB can be normal. Remember, a lot of people, RBBB is normal. It can also occur in pulmonary embolism and cor pulmonale is what we need to remember. Then what is meant by bifascicular block? Right bundle branch block plus left anterior hemi block. So what is left anterior hemi block? You can see here. See, when the left bundle branch forms, it forms for an anterior fascicle and posterior fascicle. So sometimes instead of the entire left bundle affected, only a fascicle, either anterior or posterior fascicle can be there along with the RBBB. So when RBBB full and in the left bundle only a fascicle blocked, then that is called bifascicular block is what we need to basically remember. And any new LBBB Any new left bundle branch block, if it is there, then you need to suspect acute MI. As much ST segment elevation is characteristic of acute MI, a new LBBB is also characteristic of the acute MI is what we need to remember. Understand, doctor? Now, there are few autonomic reflexes in the topic of arrhythmias that you need to know. Bejold-Jarisk reaction. For example, whenever there is an MI, or if there is any decreased preload, suppose you are dehydrated, there is a sympathetic overactivity that lead to contraction of a ventricle which is underfilled. Obviously, right? In MI, heart failure is a pump. So filling of the heart is diminished. But sympathetic overactivity is causing stimulation of heart rate that lead to the contraction of an underfilled ventricle. And that in turn will activate the mechanical receptors, which will go and stimulate the vagus. And that parasympathetic stimulation will decrease the heart rate. At the same time, it leads to vasodilatation and hypotension. And this entire cycle is called Bejold-Jarisk reaction, is what we need to basically remember. Right? Now, Bejold-Jarisk can be called vagal afferent mediated brady plus hypotension in one word, which you need to remember. Right? Now, inferior wall MI, whenever it is there, that also will lead to the vagus stimulation, leading to syncope and hypotension and heart block, is what we need to remember. Now, doctor, ventricular arrhythmias is the favorite area for the examiner. Whenever there is any ventricular tachycardia or premature ventricular complexes like what you are seeing here, how do you treat? Acute VT, amidaron, lidocaine are considered to be the treatment. How do you know there is a ventricular tachycardia? Bizarre shaped wide QRS complexes, presence of the AV dissociation, they're all indicative of ventricular tachycardia. And how do you identify ventricular extrasystoles? A lot of people in their ECG will have abnormal shaped wide QRS complexes, which are called ventricular extrasystoles. So whenever VT is there with wide QRS complex, once more you remember, wide QRS, VT, narrow QRS, it's VT. You need to identify. Unstable VT, you need to do immediate DC shock, is what we need to remember. Now, doctor, there are a few drug effects you need to know among the antiarrhythmic drugs. Whenever you give digitalis, it can lead to your hostel mess will be closed. Homa, you want to take a break? Yeah, please. I'll wait. Yeah.